Hello everyone, welcome back to the channel. Today we are diving into one of the most common and most important topics in ophthalmology, refractive errors of eyes or errors of refraction of eye. Whether you are a medical student, an ophthalmology resident, or just someone curious about how the eye focuses light to give us clear vision, this session will give you a simple structure and clinically relevant understanding. Refractive errors are the leading cause of correctable visual impairment worldwide. Almost every one of us has one or knows someone who does. But what exactly goes wrong inside the eye that turns clear image into blurred ones? Why do some people struggles to see far objects while others can't read up close? And how do we correct these errors with glasses, contact lenses, or surgery? In this lecture, we'll break it down into four key parts. How the normal eyes focuses light, the basic optics behind clear vision, types of the refractive errors, myopia, hypermetropia, astigmatism, and presbyopia explained, and clinical features and symptoms, what patients typically report, diagnosis and corrections from the retinoscopy to modern refractive surgeries. We'll more focus on the types of the refractive errors in this video and clinical features and symptoms. I will use diagrams, examples, and some analogs so that even the more complex concepts feels intuitive. So stay tuned, grab with your notes, and let's build a clear, crystal-like understanding of refractive errors, one ray of light at a time. Let's get started. First, the eye acts as an optical instrument. Eye is an optical instrument, can be compared to a camera, where eyelids act as shutter of the camera. Cornea and crystalline lenses act as the focusing system's lens of the camera. In fact, the cornea and crystalline lenses, along with aqueous humors and vitreous humors, constitute homocentric systems of lenses, which when combined in action from a very strong refractive system of the short focal length with a total power of about plus 60 diopter. Cornea is plus 43 diopter and lens is plus 17 diopter. So 43 plus 17 is equal to 60 diopter. Iris acts as a diaphragm which regulates the size of an aperture of pupil, and therefore the amount of the light entering into the eye. Choroid helps in forming the darkened interior of the cornea. Retina acts as a light sensitive plate or films on which image is formed. It should be noted that to be more precise, the functioning of the eye can be considered to be analog of the closed circuit color TV system, as depicted in this picture. Here functioning are the optical systems. This is a real image, and the eye produce inverted image, and optic nerves produces brain visual cortex, and this picture is seen by brain as real images. And similar color TV camera is used this mechanisms like this. Now let's go to the next, our main topics. This is the topic of errors of refraction. Firstly, we discuss about emmetropia. This is the normal refractive power of the eyes, that is plus 58.6 diopter. Emmetropia means this is optically normal eye. This can be defined as a state of refraction where the parallel rays, these are the parallel rays of the light coming from the infinity, are focused at the sensitive layer of the retina, and accommodation begins at rest. This is how the rays from the infinite, the parallel beams, converge on the retina and produces the sensations. Next we come to the emmetropia. Emmetropia is a condition of refractive errors, and it is defined as a state of the refractive state of refraction where the parallel rays of the light coming from the infinity with accommodation at rest are focused either in front or behind of the sensitive layer of the retina in one or both the meridians. The anisometropia includes monoocular, present in the monovascular and binocular visions. This again divided into spherical and cylindrical. Sphericals are corrected by the spectacles. These are myopia and hypermetropia, and cylindricals are corrected by the cylindrical lenses, that is astigmatism. And binocular is pathology contributed to both eyes, present only in the binocular visions, disappears in monocular visions, example Aniseikonia and Anisometropia. So the related conditions of the aphakia and pseudophakia are also discussed, will be here. Now before dive into hypermetropia, we will like to state some normal age-related changes in refractive status. At birth, the eyeball is relatively short, and the cornea is more curved, and thus having +2 to +3 hypermetropia, which is gradually reduced. By the age 5 to 7 years, the eye is the emmetropic and remains so till the age about 50 years. Next, we come to the after 50 years. After 50 years of the age, there is the tendency to develop hypermetropia. Again, which gradually increases until the extreme of the life, by which the eye has the same +2 to +3 with which it started. The senile hypermetria is due to changes in the refractive index of the crystalline lens. Further, due to cortical sclerosis, some amount of the latent hypermetropia may become manifest due to age-related weakness of the ciliary muscles functioning. Age-related index myopia may occur in some patients due to nuclear sclerosis. In such patients, near vision improves, and so may not need glasses for the near vision. This situation is called second sight. So what is second sight? You can keep the answer now. Next, we dive into hypermetropia. So what is hypermetropia? Hypermetropia or hyperopia or long-sightedness is the refractive state of the eye wherein parallel rays of the light coming from the infinity are focused behind the retina, with accommodations being at rest. Thus, the posterior focal point is the behind the retina, which therefore receives a blurred image. In simple words, hypermetropic eye has less converging power. What will be the converging power? Less than 58.6 diopter. So, what are the types of the hypermetropia? There are mainly four clinical types of the hypermetropia. That is congenital hypermetropia, simple hypermetropia, pathological hypermetropia, and secondary hypermetropia. This secondary hypermetropia again can be classified into 6 types. So let's go into congenital hypermetropia. Congenital hypermetropia क्या होता है? It is not a common condition. The age of the onset will be since birth. Okay, congenital hypermetropia can present from the birth. Anisometropia is almost always present as the condition of the unilateral due to abnormality small one eye. Magnitude of the refractive errors is high and often remains constant. That is not a progressive condition. It is not a progressive condition at all. Next we come into simple hypermetropia. Simple hypermetropia is the most commonest form, and it results from the normal biological variations in the development of eyeball and may occur in the developmental axial hypermetropia and developmental curvatural hypermetropia. Next we dive into pathological hypermetropia. Pathological hypermetropia occurs due to atypical abnormal development of the eye. The conditions indicated in microphthalmos. Next is nanophthalmos. Third one is microcornea. Fourth one is congenital posterior subluxation of lens, and fifth one is congenital aphakia. Next come into secondary hypermetropia. Secondary hypermetropia, the term secondary hypermetropia may be used for all types of the acquired hypermetropia caused by other eye disorders of factors which are not the known risk factors for simple or physiological hypermetropia. The types are mainly 6 types. First one is senile hypermetropia. It frequently designated as acquired hypermetropia occurring in the old age. The cause are index hypermetropia due to acquired cortical sclerosis in old age, and curvatural hypermetropia due to decreased curvature of the outer lens fibers developing later in life. Second one is positional hypermetropia, or it can due to posterior subluxation of the lens. Third one is acquired aphakia. It's a state of high hypermetropia occurs due to the cataract surgery, traumatic absorption of the lens, traumatic extrusion of the lens from the eyes balls, and posterior dissociation of the lens in the vitreous cavity. Fourth one is, guys, acquired consecutive hypermetropia. Consecutive hypermetropia due to surgically overcoated myopia, also known as pseudophakic hypermetropia, occurs due to implantation of an underpowered intraocular lenses. And fifth one is, guys, acquired curvatural hypermetropia, maybe due to the post-traumatic or post-inflammatory corneal fluttering. And guys, sixth one and last one is functional hypermetropia. Functional hypermetropia results from the paralysis of the accommodation as seen in the patients with third nerve palsy. In the and internal ophthalmoplegia. Oculomotor nerve. Then the grades of the hypermetropia. American Optometric Association, that is AOA, has defined the three grades of the hypermetropia as below. Low hypermetropia, this where the error is less than or equal to +2 diopter. Moderate hypermetropia, when the errors is between +2 to +5 diopter. And high hypermetropia, when the errors is greater than or equal to +5 diopter. So guys, answer. If a patient have +4 diopter, what will be the category of the grade of the hypermetropia? Comment below. This will obviously moderate hypermetropia. So now we dive into the complications of the hypermetropia. Hypermetropy is not corrected for a long time. The following complications may occur: recurrent styles, blepharitis, or chalangioin may occur, probably due to infections introduced by repeated rubbing of the eyes, which is often done to relieve from the fatigue and tiredness. Accommodative convergent squint may develop in children, usually by the age of 2 to 3 years, due to excessive use of the accommodations. Third complications is myopia may develop in some cases, which may be anisometric in unilateral hypermetropia. With corrected bilateral hypermetropia predispositions to develop the primary narrow angle glaucoma, the eye in the hypermetrosis is small with a comparative shallow anterior chamber. Due to regular increase in the size of the lens with increased age, this eyes becomes prone to an attack of the narrow angle glaucoma. First, we try to go into the investigations and diagnosis. For investigations, we go into. Sorry, I have to choose right color one, guys. Yeah, guys. First, we have to investigate it. For investigations, we go into the retinoscopy. Suspected cases of the hypermetropia are confirmed with the retinoscopy. Best method to know is the exact amount of the hypermetropia by the cycloplegics retinoscopic. So guys, reply me. What are the cycloplegics? Name some cycloplegics to use the investigations. Next one is the autorefractometry. Is a quick alternative for the retinoscopy, but is comparatively less accurate. Okay. And third one, guys, is scan ultrasonography. It may reveal a short anterior-posterior length of the eyeball in case of the axial hypermetropia. Okay, guys. Next, the treatment. For treatment, we have optical treatment. Mainly optical treatments, basic principle for the treatment to prescribe the convex plus lenses so that the light rays are brought to focus on the retina. The presence of the accommodative convergent squint, full cycloplegic correction should be given at the first sitting. If there is the associated myopia, full corrections occlusion thereby should be started. Modes of the prescriptions is convex lens. This is the convex lens. This is the convergent lens. So it focuses on the lights on the retina, which was previously behind the retina. Yes. And contact lenses indicated in unilateral hypermetropia or anisometropia. For surgical, we use the conductive keratoplasty, hypertropic PRK, hypertropic LASIK. LASIK is the laser associated in situ keratomyolysis. This is LASIK is laser associated in situ keratomyolysis. There are implantable contact lenses and refractive lens for the exchange. Before this refractive implantable contact lens, guys, I have to discuss implantable contact lenses. Advantage of this contact lenses over the spectacles includes advantage. These have advantages are the less magnification of the image and eliminations of the aberrations and prismatic effects of the thick glasses. Third one, guys, wider and better field of the vision, and fourth one is cosmetically more acceptable, and fifth one is better suited for the unilocular aphakia. And these have disadvantages also. The disadvantages ones are they are costly. These are cumbersome to wear, and especially in the old age and childhood, and corneal complications may be associated. Some blurring of the visions will be occurred if one forgot to open this and remove these contact lenses before bedtime. On the morning time, the patient may be have the blurring of the vision due because our cornea absorbs the nutrients from the air, from the outer environment. These have no blood supply. Next topic is the myopia. So what is myopia? Myopia is the short-sightedness. Is a type of the refractive errors in which parallel rays are coming from the infinity and focused in front of the retina. In hypermetropia there are the behind the retina. In myopia there are the in front of the retina. And thus, in simple words, myopic eye have an converging power greater than 58.6 diopter. So, what are the types of the myopia? The types of the myopia are axial myopia, curvatural myopia, positional myopia, index myopia. Axial myopia is a result from the increase in the anterior-posterior length of the eyeball. It is the commonest form. Or curvatural myopia occurs due to the increased curvature of the cornea, lens, or both. Positional myopia is produced by the anterior placement of the crystalline lens in the eye. And index myopia results from the increase in the refractive index of the crystalline lens associated with nuclear sclerosis. Myopia due to the excessive accommodation occurs in the patients with spasm and accommodations. So about grades of the myopia, there are 3 grades of the myopia, like hypermetropia also, but the values are varied. The low myopia, the errors are up to minus 3D. But in hypermetropia, this value were less than or equal to plus 2 diopter. And moderate myopia, there when the error is between minus 3 diopter to minus 6 diopter. In hypermetropia, this were plus 2 to plus 5 diopter. For the high myopia, so when the error is minus 6 diopter or above. In hypermetropia, this were greater than or equal to plus 5 diopter. So answer: if one have minus 5 diopter of one eye, what is the grade of the myopia? Obviously the myopia will be of moderate myopia. So about symptoms of the myopia. For symptoms, the poor vision for the distance, that is a short-sightedness, is the main symptom of the myopia. Athenopic symptoms, these athenopic symptoms may occur in patients with a small degree of the myopia. Half shutting of the eyes may be the complaint by the parents of the child. The child does so to achieve the greater clarity and stenopic vision. A change in the psychological outlook of the uncorrected myopic children is very common. Due to poor far vision and normal near vision, the children becomes introvert, studious, and prominent eyebrow. So there are many students who actually get good ranks in NEET PC or in medical lines. Also, I have seen that they wear glasses. It's not because to make fancy, because their eyes have the lesser power, minus powers, so they cannot see extremes of the distance. So they focus on the studies which are in front of them and gets good marks and gets tops in the classes. Next, the myopic eyes are typically larger and somewhat prominent. Anterior chamber is slightly deeper than the normal. Pupils are somewhat large and a bit sluggish reactive. Fundus is normal, rarely temporal myopic crescents may be seen, and magnitudes of the refractive errors. Simple myopia usually occurs between 5 and 10 years of the age and keeps on the increasing till about 18 to 20 years of the age. So now we'll discuss about the treatment of the myopia. So which lens is used? For optical corrections we use, this is what? This is concave lens. We use concave lens, contact lens, surgical like radial keratotomy, photorefractive keratotomy, PRK, photorefractive keratotomy, LASIK, refractive lenticulate extractions, intracorneal ring implantations, and refractive lens exchange and implantable contact lenses. It's in myopia, the treatment is very important. So optical treatment, we use optical treatment comprises the prescriptions of the appropriate concave lens so that a clear image is formed on the retina. The basic rule of the corrective myopia is a converse of that in the hypermetropia. That is the minimum acceptance providing maximum vision should be prescribed. In very high myopia, under corrections is always better to avoid the problems of the near vision and that of the minimifications of the image. Modes of the prescribing the concave lens are the spectacles and the contact lenses. And the advantages and disadvantages of each other, the same as they are described for the hypermetropia. Okay. The contact lens are particularly justified. In case of the high myopia, they avoid peripheral distortions and minimifications produced by the strong concave spectacle lens. For surgical treatment of the myopia, that is surgical radical keratotomy, photorefractive keratotomy, LASIK, etc., these are very popular now nowadays. For the low vision aids, LVA, these are the newer techniques. They are indicated in the patients with progressive myopia having advanced degenerative changes, where useful visions cannot be obtained with spectacles and contact lenses. Now I discuss a little bit about the preventive measures. Preventive measures for the therapeutic measures, we use cycloplegics like atropine, atropine in low strength, that is 0.01 something percentage, instilled at the night, and pyrinazepine. In pyrinazepine 2% gel is used. General measures, these are the pharmacological interventions. There will be the general measures also taken and empirically to affect the progress of the myopia include the visual hygiene. Visual hygiene is very important. Visual hygiene is very important to avoid the athenopic symptoms. The care should be taken to proper postures and adequate illuminations, especially for the near work. Clarity of the print should be good, and continuous readings, especially at night hours, should be avoided to prevent ocular fatigue. Avoidance of the excessive near works and excessive use of the video displays units, VDU, are not online games, and that's increase outdoor activity. You should increase the outdoor activity. You may go to the morning walk, may go to the travel, etc. Seeing new areas and something, and not being introvert is one of the remedy to get in the childhood to prevent the progression of the myopia. And balanced diet, vitamin A rich diet should be taken to prevent it from the myopia. And early management is associated with debilitating diseases, and there is more association with genetic association is seen in the myopia. So a pathological myopia should be strong genetic basis, and the hereditary transfer of the disease may be decreased by advising against the marriage between two individuals with the progressive myopia. However, if they do marry, they should not produce children. But no one cares. So we have to summarize the myopia and hypermetropia, the pathologies. In myopia only, there is the increased refractory power of the eyes. In early convergence of the rays, image is formed anterior to the retina, so corrective lens is used minus power lens, that is concave lens. And hypermetropia, there is a pathogenesis, is the decrease of the refractory powers of the eyes. So there will be the decrease in the converging of the rays. So image will be formed behind the retina. So corrective lens is a plus power lens. Next topic is aphakia. What is aphakia? Aphakia is literally means the absence of the crystalline lens, which produces a high degree of hypermetropia. So what are the causes of aphakia? There will be congenital absence of the lens. It is a rare condition. Surgical aphakia, there will be occurring after the removal of the lens, is the commonest presentations. And traumatic extrusions of the lens from the eyes also constitute the rare cause of the aphakia. And posterior dislocations of the lens in vitreous causes the optical aphakia. And the last one is the absorption of the lens matter, is noticed rarely after trauma in the children. So however, the aphakia from the optical point of view, it may be considered as the condition in which the lens is absent from the pupillary area. Aphakia produces a high degree of the hypermetropia. So finally, it is a cause of hypermetropia. So now dive into optics of the aphakia. Optics into aphakic eyes. So eye is highly hypermetropic. Power of the eye is plus 44 diopter, and anterior focal becomes 23.2 millimeter in front of the eye, in front of the eye, and posterior focal point is 7 millimeter behind the eye, and total loss of the accommodation will occur. Some clinical features. About clinical features, so we have to discuss about signs and symptoms. Symptoms is the defective vision. In defective vision, the main symptoms in the aphakia is marked defective vision for both far and near due to high metropia and the absence of the accommodations. Next is seeing red, that is erythropsia and blue synopsia images. That is seeing red and blue images. This occurs due to excessive entry of the ultraviolet light entry. Okay, ultraviolet light and infrared in absence of the crystalline lens. बहुत ज़्यादा UV and IV rays penetrate from the eye due to absence of the lens. This causes the erythropsia and the synopsia. And the signs is the limbal scar, and may be seen in the surgical aphakia. Then is the iridodonesis. What is iridodonesis, guys? Iridodonesis is the tremulousness of iris can be demonstrated. Iridodonesis. Jet black colored pupil, and then is the only 2 Purkinje images. Normally 4 images are seen, but normally 4 images are seen. Next one is hypermetropic small discs. That is revealed from the fundus examinations. Fundus examination shows this hypermetropic small disc. Retinoscopy and autorefractometry reveals the hypermetropia. So what is the treatments? Treatments, we use spectacles, contact lens, intraocular lens implantation, and refractive corneal surgery. What is modalities of the spectacles? These are optical corrections treatment. Many optical corrections are the treatment errors by the convex lens to appropriate power so that the image is found in front of the retina. On the retina. The spectacles. These are for spectacles. Spectacles, the prescription has been the most commonly employed method to correcting the aphakia in the past, especially in the developing countries. Presently, the use of the aphakic spectacles has decreased markedly. Roughly about 10 diopter with cylindrical lenses for the surgical induced astigmatism are required to correct the aphakia, and this will be remembered 10 diopter. Okay, 10 diopter with cylindrical lenses for the surgical induced astigmatism. Okay. However, the exact power of the glasses will differ in the individual's cases and should be estimated by the refractions. Additional plus 3 to plus 4 diopter is required for the near vision to compensate the loss of the accommodations. So what are the disadvantages, guys? Disadvantage is the image is magnified by 30%. So not useful in unilateral aphakia produced diplopia, that is pin cushion distortion. Problem second one is problem in spherical and chromatic aberrations of the thick lenses. And third one is the field vision is limited, prismatic effects of the thick glasses, and roving ring scotoma, that is jack in the box phenomenon. And the cosmetic blemism, especially in the young aphakies. So contact lens, the contact lens advantage and disadvantage are discussed previously. And intraocular lens implantation, is the best method. It's the best method available for correcting the aphakia. Therefore, it is the commonest modalities and being employed nowadays. And primary intraocular lens implantation is done during cataract surgery. Secondary intraocular lens implantation is done in already aphakic patients. Now the refractive corneal surgery. This refractive corneal surgery, hypertropic LASIK, may be tried in case of the secondary intraocular lens, cannot be implanted. So what is the full form of the LASIK, guys? LASIK means laser assisted in situ keratomylosis. Next one refractive error is pseudophakia. Pseudophakia is the commonest aphakia, is condition of the aphakia when corrected with an intraocular lens implant and referred to as pseudophakia. So a aphakic guys come to the OPD and surgically treated by intraocular lens external. So what will you call this guys? You will call it as pseudophakia or pseudophakic patients who have not real lens but have corrected their lens. So the refractive status of the pseudophakic eyes depend upon the power of the intraocular lens implanted as follows. This is not visible, but I will try to say this is emmetropia. Emmetropy, what is emmetropy? Emmetropy is the normal vision, optically normal eye. This it produced when the power of the intraocular lens implanted is exact. It is the most ideal situations. Such patients need plus glasses for the near vision only. Next is consecutive myopia. In consecutive myopia occurs when the intraocular lens implanted overcorrects the refraction of eye. Such patients require glasses to correct the myopia for the distance vision and may or may not need glasses for the near vision depending upon the degree of myopia. And the last one is third type is consecutive hypermetropia. It develops when the underpowered intraocular lens is implanted. Such patients require plus glasses for the distance vision and additional plus 2 to plus 3 diopter for the near visions. Note varying degrees of the surgically induced astigmatism is also present in the pseudophakia. So what are the signs of the pseudophakia with posterior chambers intraocular lens? The surgical scars may be seen near the limbus. Anterior chamber is slightly deeper than the normal. Mild iridodonesis, that is tremulousness of the iris, may be demonstrated. Parkinson image test shows 4 images. Pupil is blackish in color, but when light is thrown in the pupillary area, shining reflexes are observed. Presence of the intraocular lenses is confirmed on slit lamp examinations after dilating the pupil. Visual status and refractions will vary depending upon the power of the intraocular lens implanted. Next one, our next refractive error is astigmatism. Astigmatism is a type of the refractive error, so wherein the refraction varies in different meridians of the eye. Consequently, the rays of the light entering the eye cannot converge to a point focus but form a focal lines. Broadly, there are two types of the astigmatism. One is regular and another one is irregular. So, the types of the astigmatism, there are irregular astigmatism. The astigmatism is regular when the refractive power changes uniformly from one meridian to another. That is, there are two principal meridians. Depending upon the positions of the two focal lines, horizontal and vertical, in relation to the retina, the regular astigmatism is further classified into 3 types. That is simple astigmatism. Simple astigmatism wherein the rays are focused on the retina in one meridian or either in front, simple myopic astigmatism in front of the retina, and behind this will be simple hypermetropic astigmatism, the retina in other meridian, and compound myopic and compound hypermetropic. This is the compound astigmatism. In this type, the rays of the light in both the meridians are focused either on in front or behind the retina, and the condition is labeled as compound myopic or compound hypermetropic astigmatism respectively. And then is mixed type of the astigmatism. This refers to a condition wherein the light rays in one meridian are focused in front and in other meridian behind the retina. Thus, in one meridian eye is myopic and another is hypermetropic. Such patients have the comparatively less symptoms. Circle of least diffusions is formed in the retina. So, in mixed astigmatism, we can see circle of least diffusion. Another types of the astigmatism we have with the rule of WR, sorry, with the rule astigmatism and against the rule ATR astigmatism and oblique astigmatism. With the rule astigmatism, in this type, two principal meridians are placed in at the right angles to one another, but the vertical meridians is more curved than the horizontal. Thus, corrections of the astigmatism will require the concave cylinders at 180 plus minus 20 degree. For this is for concave cylinder, and another is required convex cylindrical lens will be at 90 degree plus minus 20 degree. This is called with the rule of astigmatism. With the rule astigmatism, because similar astigmatism conditions exist normally, the vertical meridian is normally rendered 0.25 diopter more in convex and then the horizontal meridian, probably by the pressure of the eyelids. Next is the against the rule astigmatism. It refers to an astigmatic conditions in which the horizontal meridians is more curved than the vertical meridians. Therefore, the corrections of this astigmatism will require the prescription of the convex cylindrical lens of 180 degree plus minus 20 degree, or concave lens, concave cylindrical lens of 90 degree plus minus 20 degree with axis. So you can remember with a mnemonic CVVC. Oblique astigmatism. Oblique astigmatism is a type of the regular astigmatism wherein the two principal meridians are not the horizontal and vertical, and through this are at the right angles to one another. Example 45 degree and 135 degree. Another one is present is bilobed. Sorry, bio. Generally have two oblique layers, so it is called bi-oblique astigmatism. In this type of the regular astigmatism, the two principal meridians are not at the right angle to each other. Example, one may be at 30 degree and another at be 100 degree. This is the bi-oblique astigmatism. Next we discuss about the procedures for giving the power of glasses. We use retinoscopy and autorefractometry. This will be discussed in the next types of the lectures. And the retinoscopy, we know objective methods to estimate the refractive status, and need a dark room and retinoscope. Distance between observer and the patients at the 66 or 50 centimeter. And autorefractometer is the estimation of the refractive errors with a machine. That is subjective method. This is objective method. This is subjective method. Next is the glass prescriptions. Glass prescription is OD minus 4.5 diopter spherical. This is OD. OD means is the right eye. Minus for concave lens. D is the power, and SP is for the spherical. At 0 plus 2.5 in the depth. This is for the correction. In OS is for the left eye. Similarly, minus 4.50 diopter spherical means it is concave lens with spherical. Here is playing the games. This minus 1 diopter psi. This is for the cylindrical lens, will be minus 1 diopter of 180 degrees corrections, and the correction will be plus 25 spherical. So a spectacle's prescription is written in the order that specifies the lens power required to correct the patient's refractive errors. It contains the values of the right eye, that is you can see OD, and OS, that is for the left eye, and sometimes both eyes. For both eyes you have to write OU. For the SPH is for the spherical or sphere. It indicates the spherical refractive errors. It corrects myopia or hypermetropia. So about values, this values minus is for the myopia and plus for the hypermetropia, and it considered will be consecutively. So this is for the concave and this will be the convex lens. For example, there minus 4.5 spherical. This is the 3 diopter of myopia. Plus 4.5 diopter spherical. This means 4.5 diopter of hypermetropia. Now comes with this guys, CYL. In CYL, guys, this integrates the cylindrical. It corrects the astigmatism. This shows the amount of the cylindrical power needed. To correct we need, that means minus 1 diopter need. The negative cylinders means that it is most commonly used, and positive cylinder is used by some ophthalmologists. But if there is no cylindrical, in this case, what will be this? This is the PL, blank or plano. There is no astigmatism. This 180 degrees. Here is 180 degrees. So what is this? It is axis. Only written when the cylindrical is present. There is a cylindrical present, so we have to write the degrees. Represents the orientations of the astigmatic meridian. This ranges from 1 to 180 degree. And important, axis has no power, only one direction. If cylindrical this 1.0 diopter with axis of 180 degrees, this means cylinder is oriented on 180 degrees. What do you mean by this and this? Add means additional. In additional there is extra plus power for near vision. This is used in presbyopia, guys. Typically after age greater than 40 years we use plus 40 years. The additional range will be plus 0.75 to plus 3.0 diopter. Example, this at 2.5 diopter spherical is for the reading glass. Oh, there also is spherical. So that the spherical glass will be added of plus 2.5 diopter. Then here it is not mentioned, but I should mention this. There is another components of this prescription. This is prism. What is prism, guys? Prism is the used in the ocular misalignment. Example, phoria and diplopia. This measured in the prism diopter or delta. Used base of, for prism we use BU for base up. For BD is for base down. For BI for base in. For BO for base out. Next component is pupillary distance. In pupillary distance between the centers of the pupils need for needed for proper lens positioning. This is the pupil, and this is the iris. This is the pupillary distance. This is the center of the pupil. This is the PD, pupillary distance. Distance of the PD is near PD is usually 3 to 4 millimeter lesser. For example, 64 millimeter. So you know guys how to read the glass prescription now. For example, we have questions OD minus 2.50 oblique minus 1.00 into 180, OS minus 1.75 minus 0.50 to 170, at plus 2.00 diopter. These are all in diopter, and PD is 63 millimeter. This means OD for the right eyes. We change the color. OD is for the right eye. This is minus. This means this have myopia, and 1 this means the astigmatism of 180 degree. And left, in the left eye OS, this is the left eye. For left eye, this is 1.75 diopter myopia, again this minus, and minus 0.5 diopter astigmatism, and 170 degree at the orientation of the lens, and additional plus 2.00 diopter is for the near task. Achha. And PD is the pupillary distance, 63 millimeter for the accurate frame fitting. And prescription types, this will be the single visions for only distance or only near. Bifocal, there will be prescription different. The second prescription type is bifocal type. Bifocal type, there's two distinct powers, distance and near visions. And third type of the progressive addition of lens, PAL. Progressive addition of lens. This no visible lineations and smooth transition from the distance to near. Listen. And prescription and duration. This duration of the prescription is 1 to 2 years only, and for children to and elderly, this changes frequently, so this will be more frequent validity and less than 1 year sometimes maybe. And so what you guys learn this DS speech only. This is the diopters sphere. PL for the plano, that is 0 powers. NV by DV, this is the near vision or distance vision. And there will be NIL, this no correction needed. So for quick revision, we discussed this, that always check the vertex distance for high powers, plus minus 5 diopters. You should always check the vertex distance. Without this will kill your job. And astigmatism prescription must be always in axis, because this is the cylindrical, and their orientation also needed. In phase bias, add only the near powers, don't add the distant power. And PD for the pupillary distance is critical in progressive lenses. So you have additionally learned this, how to read glass prescriptions. So now we discuss about the role of the refractive errors corrections in the patient with headache. Headache is due to the refractive errors is chronic and progressive, and predominantly due to second half of the day. Prolonged screen working, combined ametropia, moderate hypermetropia, and astigmatism were the risk factors. Headache impact on the quality of the life. Optical corrections and orthoptic exercises. All patients with headaches should examine properly, includes the fundus examiners, to exclude any pathology in the brain or in the eye other than refractive errors. So accommodations and its anomalies. Accommodations, our eyes have been provided with a unique mechanism by which we can give even focus the diverging rays coming from the near object on the retina in a bid to see clarity. This mechanism is called accommodations, mechanism of the accommodations. So according to the von Helmholtz's capsular theory, the process of the accommodation is achieved by a change in the shape of the lens. When the eye is at rest, that is unaccommodated, the ciliary rings is large and keep the zonules tense. Because of the zonular tension, the lens is kept compressed flat by the capsule. Contractions of the ciliary muscles is the second mechanism of the accommodation. Causes of the ciliary rings to shorten and thus releases zonular tensions on the lens capsule. This allows the elastic capsules to act unstrained to deform the lens substance. The lens then alters the shape to become more convex and conoidal. The lens assumes conoidal shape due to configuration of the anterior lens capsule, which is thinner at the center and thicker at the periphery. So the changes of the eye with the accommodation, see what will be the changes. So guys, the changes here will be ciliary muscle contraction. Second, there will be ciliary ring diameter decreases, and ciliary zonules relax, tension decrease. Anterior curvature of lens will increase, and posterior curvature of the lens, there will be no change. There will be axial diameter of the lens, this thickness will increase, and the equatorial diameter of the lens will decrease, and the lens dioptric power will increase. The far point and the near point. What the far point and near point means? This the nearest point at which the small objects can be seen clearly is called the near point, or the punctum proxima, and the distant or further points is called the far point or the punctum remotum. Proximum, this is proximal, that is near, and remotum for the remote, that is far. So far point and near points, this near point and at which they will vary with the static refractions of the eyes, as is given in an ametropic eye. Far point is infinity and near point varies with the age. In hypermetropic eye, there will be the far point is virtual and lies behind the eye. In myopic eye, it is real and lies in front of the eye. So what will be the average time to focus at near and far point? The research shows that average time for the far to near accommodation is 0.64 seconds, and average time for near to far vision per accommodation, this is 0.56 seconds. So range and amplitudes of the accommodations. The range of the accommodations will be the distance between the near point and the far point is called the range of the accommodation. Amplitude of the accommodation, the difference between the dioptric power needed to focus at the near point, this is P, and the far point, this is R, is called the amplitude of the accommodation. Say that's it. A equals to P minus R. And amplitude of the accommodation, that's the near point of the vision, that is punctum proximum, varies with the age. So rough is about in 10 years, they vary with 10 years. There will be the amplitudes of the accommodation 14 diopter and 7. In 60 years of the age, you will have 1 diopter of the amplitude of the accommodations, and the near point is out of 100 in centimeter. And there will be the anomalies of the accommodations. So what is a question arises? So what is the common drugs to use the fundoscopic test? For fundoscopic test, we use topicamide. So tropicamide used, cyclopentolate is used, and phenylephrine is used. How they work? These drugs are parasympathetic antagonists. So meaning that they block the nerve signals that normally consist of the pupil. This allows the sympathetic dilator muscles in the iris to work unopposed, causing the pupil to widen. The resulting pupil dilation provides a clear and unobstructed view of the back of the eye during the fundoscopic exam. So the anomalies about the accommodations, there is the presbyopia. Presbyopia, or the eyesight of the old age, is not an error of the refraction but a condition of the physiological insufficiency of the accommodation, leading to the progressive fall in the near vision. Then there is the paralysis of the accommodations. Paralysis of the accommodation is also known as cycloplegia, refers to the complete absence of the accommodations. There is the insufficiency of the accommodations. The term insufficiency of the accommodation is used. And so when the accommodative power is significantly less than the normal physiological limits for the patients. Other types are anisometropia. Anisometropia is an optical state with equal refractions in the two eyes is termed as isometropia. When the total diffraction of the two eye is unequal, the condition is called anisometropia. Aniseikonia. Aniseikonia is defined as a condition wherein the image projected to the visual cortex from the two retina are abnormally equal in the size or in shape. Up to 5%, well speaking, up to 5% is well tolerated, but greater than 5% it cannot be tolerated. So here are the types of the Anisoconia. In the Anisoconia, clinical types are spherical, cylindrical, prismatic, pincushion-like. This is spherical, this is cylindrical, this is prismatic, this is pincushion, this is barrel-like, this is oblique distortion. In normalized, if you see this image and one eye and other image that is the defective eye, that with there will be seen these images. These images you can see when you, if you have this problem of anisoconia. And there will be the problem of you will see double images, that is sometimes diplopia will be symptom. There is the symptoms in symptoms there will be Athenopia, that is the eye ache. There is the eye ache, the brow ache and tiredness of the eyes. And there will be the diplopia also. Diplopia due to difficulty of the binocular vision when the differences of the image of the two eyes is more than greater than 5%. And third one is difficulty in the depth perception often noticed. What is the treatment? For aniseikonia, there is the treatment is optical aniseikonia may be corrected by the anisoconic glasses, contact lenses or the intraocular lenses or other refractive surgery depending upon the situation. Retinal aniseikonia may be corrected by the treating the cause, and cortical aniseikonia is difficult to treat, frankly speaking. So advantages of the spectacles and contact lens previously I told, but again I will repeat this. Spectacles are of types are single vision lenses, bifocal lenses, trifocal lenses and multifocal or varifocal lenses or progressive lenses. The contact lens is an artificial device which whose front surface substitutes the anterior surface of the cornea. Types of the corneal lenses, depending upon the nature of the contact lenses, can be divided into following types. This is hard lenses manufactured from the PMMA, that is polymethyl methacrylate, and rigid gas permeability lenses are made up of materials which are permeable to oxygen, and softens and made up of the HEMA for the hydroxy methyl methacrylate. You should remember PMMA. This means that the polymethyl methacrylate, and HEMA for hydroxymethyl methacrylate. Indications of the contact lenses used. Optical indications include the Anisometropia, unilateral Aphakia, high myopia, and therapeutic indications are as well as follows. So the corneal diseases, the bandage soft contact lenses are used following the keratoplasty and microcorneal perforations. Preventive medications include prevention of the symblepharon and restorations of the follicles in the chemical burns and exposure of the keratitis. Diagnostic indications include using the doing gonioscopy and electroretinography, operative indications, and there is the cosmetic indications, and occupational indications include used by sportsmen and pilots. What are the contraindications for the contact lenses? Contact lenses are mental incompetence with four motivations: chronic dacryocystitis. In this dacryocystitis, this means the inflammation of lacrimal gland. We call the inflammation of the lacrimal glands and necroval जो structure होता है, this structures will be inflamed and cause the dacryocystitis. Chronic blepharitis and recurrent styles, and chronic conjunctivitis and dry eye syndromes. The corneal dystrophies and degenerations will occur, and there will be the recurrent disease like episcleritis and the scleritis. These are the conditions of the contact lens use. Role of the refractive surgery. These are the comes under the treatment. For changing the refractive states of the eyes and decrease the estimated dependency of the glasses or contact lenses. Techniques affects the cornea and or crystalline lenses, as these are the principal refracting components of the eye. For myopia, hypermetropia, and astigmatism and presbyopia, sometimes a combination of these may need to be corrected. Methods include surgical remodeling of the cornea by excimer's lasers, lens implantation, or the lens replacement is used. What are the indications of the refractive surgery, guys? These are bilateral high refractive errors, anisometropia and anisometric myopia, and accommodative esotropia. What are the contraindications? Contraindications in pregnant women, medical conditions like glaucoma, diabetes, vascular disease, or the autoimmune disease, keratoconus and progressive thinning of the cornea, and years is below 20. What are the refractive procedures? We use refractive procedures. These are aimed at changing the refractions of the eyes by altering the cornea or the lens. Principal refracting components. Corrections of the myopia. Correction of the myopia, we use surface ablations procedures to correct low to moderate degrees, lesser in the in situ keratomyolysis, that is LASIK, corrected moderate to high myopia. Refractive lenticulus extractions, that is corrections of the myopia and myopic astigmatism. The clear lens exchange for the good visual results. For the iris clip lenses, we use our phakic posterior chambers, that is implant or the contact lens. This is -3 diopter to -20.5 diopter. What will correction of the hypermetropia to now treatment of the hypermetropia is the surface ablation procedures, LASIK correction up to 4D diopter, and conductive keratoplasty applications of the radio frequency energy to the corneal stroma, correct low to moderate hypermetropia and the hypermetropic astigmatism, and lesser thermal keratoplasty low to hypermetropia. The correction of the astigmatism, to correct the astigmatism, we use the limbal relaxation incision or arcuate keratoplasty. PRK and LASIK are LASIK, or it is not right, is LASIK, SIK, LASIK. This is correct up to +3 diopter. LASIK up to +5 diopter. Sorry, I was wrong. This PRK and LASIK correct up to +3 diopters, and LASIK up to +5 diopter. Lens surgery, toric intraocular lens implantation, and conductive keratoplasty is used. And this is the corrections for the presbyopia. For correction of the presbyopia, the lens extractions and implantations of the multifocal intraocular lenses are used, and laser-induced monovisions or laser refractive surgery in one eye for distance and fellow for the near. So thank you guys, and thank you for listening to the lecture.